Dr. Basavaraj.
The next speaker also can be ready so that we don't waste any time.
Good afternoon, everybody. I have a voiceover PPT, so let's see it.
Optic nerve reducers are refractive calcified nodules located over and within the optic disc. The global prevalence ranges between 0.3% and 2.4%. In adults, the prevalence is 0.4 to 2.5%, while in children it's 0.3%. Optic nerve reduction are postulated to occur secondary to slowing of axoplasmic fluid following the compromise of blood supply to optic disc, leading to the accumulation of calcified and degenerated mitochondria. Optic nerve reduction is a grade neutral and is a common cause of pseudopapular edema, leading to a misdiagnosis. About 87% of optic nerve reduction have a visual field defect. Optic nerve reduction act as an independent risk factor for non-arthritic antihistaminic optic neuropathy and also are associated with many vascular complications like plane shift hemorrhages, CRO, and pericapillary CNV. This was a single-center prospective study where all patients who were diagnosed with optic nerve reduction at our center between January 2023 and June 2024 were included in the study. Detailed ocular and systemic evaluation was done on these patients. Multimodal imaging on different platforms was performed and necessary radiological imaging were done. A total of 38 eyes of 20 patients were included in the study, among which 14 patients were male and 6 patients were females. There were 3 male children in the study population. 18% of the patients had bilateral involvement, while 2 patients had unilateral involvement. At presentation, 3 patients were asymptomatic, while 5 patients presented with decreased vision, and 11 patients had a different or a misdiagnosis at the presentation. About 32 eyes in the study group had a visual field defect at the baseline. There were different associations of the patients with optic nerve reduction like CNVM, retinitis pigmentosa, fundal coloboma, amblyopia, and incidental post-traumatic reflex hemorrhage. Here are some of the representative cases. In case 1 is a 37-year-old female who presented with headache and eye strain and was diagnosed as benign intracranial hypertension elsewhere and was on estrazolamide for past 4 years. At presentation, patient was subjected to multimodal imaging and we diagnosed optic nerve occlusion based upon the fundus autofluorescence findings. In our study, about 24 eyes were on treatment for benign intracranial hypertension at presentation. Case 2 is of a 11-year-old male child who was diagnosed as optic neuritis and was treated unsuccessfully with 8 doses of intravenous methylprednisolone. Here, at our center, FFA was done and it showed peripapillary CNV. Patient was successfully treated with anti-VEGF. Case 3 is a 31-year-old female who was diagnosed as retinitis pigmentosa with benign intracranial hypertension and treated with Diamox and topiramate for 4 years, while CSF analysis was within normal limits. On multimodal imaging, both the optic nerve head showed multiple irregular deposits over the surface and multiple bony spiculated pigments in the periphery. Fundus autofluorescence showed hyperautofluorescent area over the optic nerve head, clinching the diagnosis of optic nerve occlusion with retinitis pigmentosa. 87% of patients with optic nerve occlusion have been described to have visual field defect. In our study, about 78% of patients had peripheral visual field defects, while 10% had enlarged blind spot, and 5% had isolated scotoma. Different platforms are available as a part of multimodal imaging for fundus imaging. In this study, Optox imaging system Topcon and Heidelberg imaging system were employed for fundus picture and fundus autofluorescence. All of them have their own limitations. Among the following, Topcon fundus picture and Heidelberg fundus autofluorescence do have their edge ahead in the diagnosis of optic nerve drusen. Optic nerve drusen is a novel technique to identify the presence and locate the site of the optic nerve drusen. 90% of eyes had PHOMS adjacent to optic nerve head and 94% of eyes had hyperreflective mass above the lamina. Conclusion: it is necessary to differentiate between pseudo and true disc edema, and optic nerve drusen should be ruled out before making a definitive diagnosis of papillary edema. We can educate the patient and create an awareness about the field effect and associated risk of developing complication associated with optic nerve drusen. Optic nerve drusen is a benign condition and a majority of patients requires observation only. Thank you.
Thank you. Very nice study. So, as you saw, so many ophthalmologists were treating them as IH. So, what message do you want to give these ophthalmologists when they see such cases? How should they go about?
A careful disc examination is the key feature here, ma'am. If you see any textbook, there is a difference, like there is a table where we can differentiate between pseudo disc edema and then true disc edema. Everything, like sometimes it might overlap among all those things, but two most important features are, one is the obscuration of the blood vessels. If the blood vessels around the disc or also in the peripapillary area is not obscured, it means you are dealing with a pseudopapilledema. That is one important point. Second point is the anomalous vascular branching, the bifurcation or else trifurcation of the vessels. If you see any bifurcation or trifurcation of the vessels over the disc, it means again you are dealing with the pseudopapilledema. These two are the most important features. These two features holds true for the other causes of pseudopapilledema, like hypermetropic eyes as well as myopic eyes.
And if they have a chance to do investigations,
Yes,
which
unnecessary
investigation?
It's one more thing, like it gives me it makes me happy that like whenever I stop 4-year 5-year-old follow patients with our dime or topiramate and other things, it gives me very like a kind of a pleasure that I'm going to stop all the drugs, and then I'm going to say that I'm just want to observe you every yearly with all these basic investigation. I see that happiness in my patient eyes. That is the one which gave me some kind of stimulation to do this study.
So you can say a simple ultrasound or a fundus autofluorescence will help.
These two are the most important things. Thank you.
What about your axial length and retinoscopy?
Sir, I didn't do any axial length because, sir, when we have a autofluorescence, we're not going to do ultrasound, because ultrasound is a subjective test. Unless you are looking it for like optic head drusen on the ultrasound, you are going to label it as a ONH. Otherwise, you might miss an ultrasound also, sir.
With the advent of your OCT and autofluorescence, that retinoscopy and axial length has taken a back seat, no?
Yes, sir.
Thank you.
Thank you, sir.